Welcome back to another deep dive. Today we're tackling one of those calls you hear overhead, one of those patients you see rolling in, just gets your attention. Atrial fibrillation with rapid ventricular response, AFib with RVR, you know the one.
No.
The patient feels like their heart is just throwing an absolute rave in their chest, right? And they are definitely not having a good time.
Yeah.
And on the monitor, yeah, it looks like a toddler just scribbled all over the screen. That rate screaming past 160, sometimes higher. It's that classic irregular rhythm, narrow QRS, no P waves anywhere. And, it's not artifact. This is the real deal. So our goal today, our mission, is really to get that game plan just burned into your brain so you can react fast, react confidently every single time you see this.
It really is such a common scenario, isn't it? And, understanding not just what you need to do, but why you're doing it, that's absolutely crucial here. What's really striking is, like you said, how often we see it and how quickly those decisions need to be made.
Okay, so let's break down this chaos a bit. We talked about this electrical temper tantrum in the heart. What's actually going on inside there?
Yeah, so normally you've got this really neat, orderly electrical path, right? SA node fires, goes down the pathways nice and clean. But in AFib, that's all out the window. You've got hundreds, literally hundreds of different electrical signals firing off totally randomly within the atria. Think of it like just constant, overwhelming noise coming from the apartment upstairs.
Okay, right.
And the ventricles downstairs, they're just getting bombarded. They're trying to listen, trying to respond to every signal that manages to squeak through the AV nodes. So they just beat as fast as they possibly can whenever a signal gets through. They're sort of desperately trying to get back to that nice one-to-one beat we like to see. But with all that noise upstairs, the ventricular rate just climbs and gets totally erratic. That's your RVR, the rapid ventricular response. It's not just fast, it's completely random.
Right. And this is where it gets really critical, life-saving even. Before you even think about reaching for a medication, there's that one single question that trumps everything else, isn't there? Is this patient stable or are they unstable? So what are we looking for? What screams unstable to you? Are they sweating buckets, clutching their chest? Is their blood pressure just, in the toilet?
Exactly.
Or maybe a big change in their mental status, or they just look like they're about to circle the drain, about to hit that arrest button.
Yeah, absolutely. If the answer is yes to any of those hypotension, acute heart failure signs, altered mental status, chest pain suggesting ischemia, the debate is just over. These aren't subtle things we're talking about. These are usually pretty obvious signs that things are going south quickly.
Okay.
And if that's the case, and you've got the doc there, orders are in, you get the pads on, and you deliver synchronized cardioversion, usually starting around 200 joules, we're not asking politely anymore. We are telling that heart forcefully to shut up and reset now.
Right. Hit the reset button.
Exactly. And importantly, always remember sedation if you possibly can, if they're stable enough for even a quick push. The humane thing, the right plan of care, is to make sure they barely remember getting shocked. And think about analgesia, too, before and after.
Good point. Okay, so that's unstable. Immediate action, electricity. But let's shift gears. What about the more maybe common scenario? The patient comes in, feels palpitations, maybe a bit weak. They think they're on a blood thinner. Maybe they remember something about avoiding spinach, but they're hazy on which pills they took this morning or even what heart meds they're supposed to be on.
Yeah, classic story.
Symptoms started maybe after they were working outside in the heat. Triage vitals show, let's say, a heart rate bouncing between 140 and 200.
Yeah.
EKG confirms it. Irregular, narrow QRS, no Ps. But importantly, no chest pain right now. BP's okay, maybe 126 over 80. Are they stable? Looks like it.
Yes, that patient is stable.
Okay, so now what? We know what to focus on here, right? But there are basically two main paths we can go down, and usually one of them works.
Right. For the stable patient, you're generally looking at either rate control or rhythm control.
Let's start with rate control. That feels like the classic approach, almost second nature for a lot of us.
It really is. And with rate control, like the name says, you're not necessarily stopping that chaotic party upstairs in the atria. You're not fixing the AFib itself, not immediately anyway. Instead, you're basically putting security at the door of the ventricles, the AV node. You're slowing down how many of those chaotic atrial signals actually get through to make the ventricles beat.
Okay, slowing the response.
Exactly. The goal is just to get their heart rate down to a more reasonable level, usually less than 110, and keep it there. Slow things down, let the heart fill properly, but you absolutely have to keep a close eye on their blood pressure while you do it because all these meds can drop it.
Makes sense. So what are our go-to drugs for rate control? assuming no major heart failure concerns.
Yeah, if there's no significant heart failure, diltiazem is often your first stop. It's a calcium channel blocker, usually a weight-based bolus somewhere in the 10 to 25 milligram range. Then you can start a drip, maybe 5 to 15 milligrams per hour.
Okay.
Metoprolol is another great option, a beta blocker, typically given as 5 milligrams IV push, and you can repeat that every 5 minutes or so, up to maybe 3 doses, so 15 milligrams total.
And what if they do have a history of heart failure?
Yeah.
Like significant systolic dysfunction?
Ah, good question. That changes things. If there's significant heart failure, you might lean towards digoxin. Dosing can vary a bit. Sometimes it's 250 mics IV push, maybe repeated once, or sometimes a single 500 mic dose. Cardiology often has specific preferences there, so it's worth checking.
Right.
And then there's amiodarone. It kind of sits in its own category because it affects rhythm too, but it does slow the rate. It's usually your fallback if the others aren't working or aren't appropriate. Standard loading dose, 150 milligrams IV bolus over 10 minutes, followed by a drip at 1 milligram per minute.
Okay, so those are the main rate control players. Diltiazem, metoprolol, maybe digoxin or amiodarone, depending on the situation. Now, what about the other strategy? Rhythm control. This feels a bit like telling the heart, okay, party's over, it's too late for all this noise, shut it down.
Yeah, that's a good way to put it. Rhythm control aims to actually convert the heart back into a normal sinus rhythm. And while synchronized cardioversion, the electrical kind, is still the most definitive way, especially if they become unstable.
Right.
We are seeing more chemical cardioversion attempts in the ER for stable patients.
And what's the go-to drug for that, generally?
Procainamide is often considered the preferred antiarrhythmic for chemical cardioversion in this setting, especially if rate control isn't enough or you really want to flip them back. Now, procainamide is one of those drugs we don't use every single day, right? So you'll definitely want to double check, maybe triple check those dosages and infusion rates with another nurse. Hopefully Jesse's working that day.
Yeah, always good to have that second set of eyes.
Absolutely. But even with chemical options, controlled electrical cardioversion is still very much on the table for stable patients if meds fail or if it's preferred. So it's really vital to just have that possibility on your radar, be ready, have the equipment nearby the monitor, pads, sedation meds.
Okay, so let's say you've done it, you've intervened, maybe you shocked the unstable patient, maybe you got the stable patient's rate down nicely with diltiazem, or maybe you successfully cardioverted them chemically or electrically back to sinus rhythm. They feel better, vitals look good, time to write discharge papers.
Almost certainly not. I'd say, yeah, 9 out of 10 times, probably more, the answer is going to be no, not yet.
Why not?
Well, these patients really need monitoring, usually for at least a day or two, sometimes longer. There's always that chance they could slip back into AFib or back into RVR, especially as the initial effects of our ER treatments start to wear off. If they're on an ongoing drip, like diltiazem or amiodarone, cardiology needs to come see them, figure out the transition to oral meds, make adjustments. That usually won't happen same day. And even if you flip the rhythm back to normal sinus, they still need monitoring to make sure they stay in sinus.
Okay, makes sense. Continued monitoring is key. So you've stabilized them, though. They're comfortable, rates controlled, BUT's fine, just waiting for that inpatient bed.
Yeah.
Is there anything else we need to be worried about right now? I feel like I'm setting you up here.
You are, but it's the most important setup. Yes, there is something absolutely critical we need to consider. Clots. The risk of stroke or PE.
Right. Thromboembolism.
Exactly. That inherent risk of clot formation in the atria that comes with AFib baseline.
Right.
Gets potentially worse with everything that's just happened. The RVR itself causes more blood stasis, more turbulence in those fibrillating atria. And here's the really scary part. Rapidly changing that rate, or especially cardioverting someone back to sinus rhythm, whether with electricity or drugs, that can be the trigger that dislodges a clot that might have formed.
Oh, wow.
Think about it. Cardioverting someone into sinus is almost like loading a clot in the atrial chamber. As soon as that SA node fires a good, strong, coordinated signal boom, the gun goes off. That clot gets ejected.
So from the atria.
To the ventricle, then either out the aorta to the brain stroke, or out the pulmonary artery to the lungs PE. Both are bad. Really bad.
Okay. So we absolutely have to be watching for signs of a stroke or PE after any of these interventions, even if the rhythm looks great.
Vigilance is key, and this underscores the absolute importance of anticoagulation. Whether it's starting a heparin drip acutely in the ER while you wait for decisions, or ensuring they are initiated on appropriate long-term oral anticoagulation before they leave the hospital. Honestly, starting that anticoagulation discussion and plan in the ER is probably the single most important thing you'll do after you get their heart rate or rhythm stabilized. It prevents devastating future events.
Wow. Okay, that's huge. So let's try and bring this all together then, boil it down for practice.
Yeah.
The core assessment is pretty straightforward, right? Is it irregular?
No.
Check. Narrow QRS? Check. No Ps? Check. Then the big fork in the road, stable or unstable.
Exactly. If they're unstable, hypotensive, altered chest pain, failing heart,
Right.
they get the shock. Now, synchronized cardioversion,
Okay.
if they are stable, then you've got a choice. You can slow it down with rate-controlled diltiazem, metoprolol, maybe digoxin or amiodarone, or you can try to flip it back to normal sinus with rhythm control, maybe procainamide or elective cardioversion.
Yeah.
And whatever you do, keep watching that heart rate and blood pressure like a hawk.
Got it. But crucially, no matter what you do to the rate or the rhythm, you absolutely have to address that stroke or PE risk.
Yeah.
Anticoagulation is paramount.
Paramount. It cannot be overlooked. And this brings up a really interesting point for all of us as ER nurses, doesn't it? How does really understanding this significant clot risk and the absolute necessity for anticoagulation change how you approach patient education right there in the ER? Especially for those patients who, like in your earlier example, come in and they're foggy about their meds. Maybe they don't even know what heart pills they're supposed to be on.
That's it. Yeah, that's a really good question.
Yeah.
How do we effectively communicate that risk and the importance of anticoagulation in that often chaotic environment?
Exactly. Something to definitely mull over until our next deep dive.